If you're trying to conceive and feeling overwhelmed with fertility advice, then this podcast is for you. Welcome to Don't Tell Me to Relax, your fertility podcast and antidote to unhelpful fertility information. I'm Hannah, a fertility acupuncturist, teacher and campaigner for better fertility education. This podcast aims to empower and inform you about your menstrual cycle and fertility. It's basically all that information you didn't get in sex ed at school, with the aim of improving your understanding of your reproductive health and optimizing your fertility. Hello, everybody. Thank you for joining us today. I am very excited. I say that at the beginning of every podcast episode because I am always really excited to be recording a podcast, but I am particularly excited today because I'm joined by Louise, who is a fellow acupuncturist and fertility support trained acupuncturist, which we talk about a lot. And Louise and I did a conference the other week, which was both terrifying and exciting at the same time. And Louise is a specialist, is endo. So when we were meeting and talking, I was like, you've got to come on the podcast because endometriosis is a big problem that we see a lot in clinic. And I know a lot of people who are trying to conceive with a history of endometriosis as well. So I was like, come on. Tell us about your work and your specialism and what you do. So, Louise, thank you for joining me today.
Thanks for having me, Hannah. I just love any opportunity to talk about endo.
Do you want to just introduce yourself and say like what you do, where you work, and how you specialise in this area?
Yep. So I'm based actually a very long way from you because I'm in Newcastle upon Tyne in the desolate north of England. And there's not many people up here doing what I'm doing. There's me and Laura in Newcastle. So as a result, we've had like so many of the fertility population actually of people seeking out that kind of natural support, you know, for trying to conceive. So we've been lucky because we've seen such a broad demographic together. But for some reason, I started getting a lot of endometriosis patients and I wasn't even advertising like, I love endo. You know, when you just start realizing, oh, it's endo after endo after endo. So it was seeing a lot of these endometriosis patients that made me start to dig deeper, like become a little bit obsessed with it. I use acupuncture and herbal medicine to support them. But I also then like stepped a bit into the functional medicine world just to kind of learn more about how that condition kind of relates to the rest of the body, you know, in terms of not just the gynae side of it and trying to conceive, but all the issues with the gut and the immune system. So it then gave me this really broad approach to start working with the women trying to conceive with endometriosis.
Yeah. And can you, before we sort of dive into that, can you just sort of give us a description of what, and I mean, I know it's controversial, isn't it, still, because they don't actually know, but in your opinion, what is endometriosis? How does it sort of show itself? How does it present itself? And I know there's a huge range, but as a sort of general sort of rule, so we can get an understanding of it for people who maybe don't know, can you sort of explain a little bit about it?
Yeah, and I'll try and keep it as simple as possible because it is complex. So endometriosis develops when the cells that are usually in the uterus end up outside of the uterus and they implant themselves into, usually it's the pelvis, but it can spread further out. Once these cells are planted, they turn into what we call lesions. So when the woman, and I say women, obviously people with endometriosis can be trans as well, but I'm going to be using the terms she and women here. When a woman is having a period, her uterus is bleeding, but also those lesions in the body are bleeding. So that blood is filling up in the body with nowhere really to go. The body gets confused and it tries to tackle that blood that shouldn't be there. It knows what it's doing with a bleeding uterus, but it doesn't know what it's doing with these bleeding lesions in the body. So it tries to tackle it by, you know, attacking it, and this causes all this inflammation. I think women might start to suspect there's something going on, or we might suspect there's something more going on when their periods are extremely painful. That's definitely one of the symptoms. It can cause really painful periods, sometimes really heavy periods, not always, but sometimes when you see pain and heaviness go hand in hand, you think this could be an endo picture. But then because the lesions can implant onto the bowel as well, and sometimes the ovaries, the fallopian tubes, they can get stuck to the bowel because of this mess. You start to notice bowel pain as well. And often women might be written off as having like IBS for years because there's bowel involvement. So that's generally how you tend to see it present with symptoms.
And in terms of sort of, there's always, from what I understand, there's been this huge campaign around the time it takes to get a diagnosis for endometriosis. So I've got in my mind like the 8 years is the average time. Why does it take so long for people to get that diagnosis? What is it that means that it's, not immediately spotted and treated?
I think if we take the example of a teenage girl, she's probably taken by her mum to the GP, painful periods, and we all know what the GP's response to that is. It's like, let's put you on the pill. Let's make these periods slightly easier to deal with. So a girl or a young woman might end up on the pill for quite a few years to try and deal with the symptoms. For some, it might work, and those symptoms might be slightly suppressed. And you can't treat endo with the pill, but sometimes you can suppress some of the symptoms or minimize it slightly. So you might be on the pill for a number of years, but you might think, I'm still not right. I'm still in a bit of discomfort a lot of the time. Or you get some women for whom the pill just doesn't work. So then the doctors are saying, let's also try these painkillers. Let's try cocodamol, codeine, ibuprofen. So they try and manage it through painkillers. For some, those work. For some they don't at all. They don't touch the sides. Then they're like, well, let's try the Mirena coil. So the GP goes through all these different approaches to try and deal with the woman's menstrual pain, rather than going right at the start, maybe let's just do some investigations, just to see what this is. Investigations come a long way down the line. And often so many women have told us that the symptoms they're saying they've got to the doctor are also like, well, it's probably just IBS, isn't it? That bloating, that kind of crampy bowel sensation, it's probably IBS. So it can take a long time of going back to the doctor again and again. This didn't work, this didn't work, this didn't work, which is why I think 8 years down the line, they might finally be referred to a gynecologist who will then do their investigations and finally say, yeah, this is endo.
And so to diagnose endo, what are the investigations that need to happen to get that conclusive, this is endometriosis, this is not period pain or IBS? How does that happen?
One of the first investigations that they are likely to do, because it's cheap and generally non-invasive, is an ultrasound scan. So as an ultrasound scan might show them that there's something on the ovary called like an endometriotic cyst. Now, a lot of women might have endometriosis, but not necessarily have these endometriotic cysts. So on an ultrasound, they might not see anything. And then, of course, they might dismiss it and say, you're fine. And again, repeat trips back to the doctor, like, I'm still having problems. At that point, a specialist might say, you know what, let's maybe do an MRI, or let's maybe do a laparoscopy. So laparoscopy is considered gold standard. If you get a surgeon, a specialist surgeon who is an endometriosis specialist, going in, opening up and looking in with their eyes, they're the ones that can say, usually, like definitively, this is endometriosis. An MRI can spot, can show more than an ultrasound, but it's still not as good as a laparoscopy.
Mm. And in terms of if they find endometriosis, what happens then?
So there's two things that can happen. We've got an IVF clinic up in Newcastle who will do the investigation. So they'll go in and do the laparoscopy, open a woman up and say, oh yeah, you've got endo. Right, close her up, and we'll leave her for someone else to deal with, because they aren't necessarily qualified to go in and do the endometriosis surgery. In an ideal world, you'll have someone who is doing both investigative and diagnostic and treating it at the same time. So they'll go in, they'll see that there's endo, and then they'll know what to do with that. But sometimes what you need is a team of surgeons, because if there's bowel involvement, you might want the gynae surgeon and the bowel surgeon, sometimes a bladder surgeon as well. So sometimes having the investigation done first confirms the extent of it, and then they know what they need to do if they need extra support when they're in there.
And I've had somebody recently in the community clinic who had to have that. She had to have two surgeons. She had to have a gynae and a bowel surgeon. And she had been waiting, I think it was about 6 years for her surgery. She tried various different things like injections, painkillers, everything that you've said. and was so debilitated. But she had been on this list. I mean, obviously there was COVID as well in between, but it just took years and years and years. Is that the same everywhere, or is it different in different places? Do you know?
I think it can be a bit of a postcode lottery. And you raise a good point there. They do use these injections which suppress hormones and almost put you into menopause. And that is one way of trying to kind of stave things off for as long as possible. In Newcastle, the average waiting time or in the Northeast in general, you wait about 2 years for surgery. It was complicated with the pandemic, wasn't it? That added on probably even longer for women waiting. It's hard when you need a team of the surgeons. You're trying to line up timetables of more than one person. And I've got a girl at the moment who was, after 18 months, was literally about to have her surgery with the 3 specialists. And then, of course, it was either the nurses' strike or the doctor's strike. So suddenly it's another 3 to 4 months of waiting again.
Yeah. And in terms of like its impact on fertility, because obviously endometriosis is a condition on its own, but people with endometriosis who are trying to conceive struggle more to conceive, in terms of the reasons why people struggle with fertility. Endo is up there, isn't it, as one of the main reasons. So can you explain to us why that is? Why does endometriosis impact people's fertility so much?
Yeah, there's generally 2 ways that we can kind of see the impact. And the really obvious one is the anatomical impact, because if a woman has got endo, sometimes there can be kind of distortions. The ovary might be in the wrong place. One of my girls, her fallopian tube was wrapped around the ovary, and that was like attached to the bowel. So there was no eggs getting through those tubes. So when you've got the anatomical distortions, it can make the meeting of the egg and sperm almost impossible. And that's the kind of stuff that sometimes they go in and they do surgery. And that patient I just mentioned to you, once that her fallopian tube was freed up and it was extracted from the bowel, she thought she'd need IVF, but she conceived naturally. So you can free up the anatomy and people can fall pregnant very quickly once that's done. Then you've got the other weird aspect of endo where there's nothing going on anatomically. The ovaries are clear, the tubes are clear, there's no adhesions causing distortions, and yet they're still not falling pregnant. And we think that is more to do with the inflammation that is being caused by the endo. So when you've got these high levels of inflammation, which are there all the time because the lesions are there all the time, it means that inflammation is like damaging that delicate egg cycle. It can actually kill off the sperm, and then it can also impact the lining of the uterus that an embryo would implant into. So that's 3 stages of the fertility process, which can be like hampered by the presence of endo. But I really want women also to be reassured that, sometimes you could have endo that looks like it would maybe be giving off massive amounts of inflammation because there's so much of it. And I've got a girl who, her experience was getting better and better with all the treatment we were doing. So no more pain, period so much better. But when she'd gone for an investigation, they said, yeah, your endo has really, really progressed. So you think, surely the chances of pregnancy are less and less here. But actually, because we'd made her body able to cope with the presence of the endo, and it must have had an impact on reducing the inflammation, despite the fact it progressed, she's fallen pregnant naturally. So the extent of endo doesn't always equate to your ability to get pregnant.
And it's so complex, isn't it? And like you've just highlighted, it's so unique to every person, and it doesn't always make sense or follow a pattern. Exactly.
It's the weirdest condition that I've worked with in many ways, because PCOS, you tend to see patterns with it, and yes, with endo we see the patterns of the heavy pain periods, the painful periods, but even I could have 10 endo women in a room, and I could tell you how different it is for each one, and the pain they experience or their ability to get pregnant.
Yeah, it's interesting, isn't it? Because what I've seen is similar in clinic, in that some people get their endometriosis treated, so they have surgery, and they're often given like a 6-month window, sort of go and try and conceive, see what happens. And some people do fall pregnant in that time, but some people, they've had all the endometriosis treated, but they still don't fall pregnant naturally. And on one level, there appears to be no problem. The endometriosis is gone, their periods are okay, but it's still, there's something about that inflammation, or it's difficult to pinpoint what it actually is, of why they then still go on to struggle to conceive. Age is okay, sperm is okay.
Yeah,
And
exactly.
it's really, really complicated.
It is. And I've almost learned to exercise a level of patience with like that woman that I mentioned to you. We've been working together for 3 years, and she was literally just about to have surgery in a couple of months' time. And she took us, we've both been taken by surprise because she's just fallen pregnant naturally. So we were managing the endo, not necessarily thinking she was going to fall pregnant naturally, but just by managing it and maintaining it and helping her body to cope with it, she got there eventually. So there's that element as well of just being patient. And when you get told, right, you've got 6 months now with a lovely clear window, you've got to fall pregnant, you will fall pregnant. But a woman hears that 6 months and suddenly the pressure is on. I have to conceive in these next 6 months.
Yeah.
And I think when we try and remove that time pressure, then there's that ability for the body to think, okay, I'm not under pressure to conceive.
Yeah. Yeah. And from, I guess from like a Western medicine perspective, so treatment for endometriosis is surgery, contraception, switching off the hormones with the injection. What else is there? Is there anything else?
There's the management of the painkillers.
Yeah.
But no, I mean, surgery is that's the gold standard for tackling it.
Yeah.
There's some new research that you might have seen coming out about the bacterial side of things.
Yeah.
They're starting to explore that maybe endo could be tackled by, killing off the presence of a certain bacteria in the body. I mean, this is really new.
Yeah.
But that would be amazing. Could we tackle endo just by giving antibiotics?
Yeah.
Which for us working in the field feels a bit like, imagine just giving some antibiotics and then resolving the endo.
So Louise, from your perspective, what approach do you take? So you take a holistic approach, obviously. What are the main ways that you treat endometriosis?
So first of all, I look at, how is the period bothering them? Because often that's why patients might seek us out as well, just how distressing the period is. So I approach the period using things like acupuncture, herbal medicine. I really love herbs for endo. I then try and look at just like you will, you say, tell me about your day-to-day life. Let's look at, how you're living, sleeping, eating, all of this. And sometimes just by making changes to their, what they're eating during the day can make a massive difference. And for anyone listening to this, it can be really good to experiment with your diet. And there's loads of stuff on the internet about, try taking out gluten for a bit, seeing how you feel, try taking out dairy. So I'll often give patients a food plan to work with, to try for 4 to 8 weeks, because that can make such a difference. And then I will look at, what's going on with any kind of gut distress, and I'll work on that with them, whether it's constipation, diarrhea, or the one that fluctuates between the two. And then, of course, I start to get into the nitty-gritty of if they're trying for a baby, we really want to look at what is the health of the cycle. And just like you love the BBT charting, that can give you some really good insight into how the endo is behaving. So I might ask them to do a couple of charts for me. And then I tend to prescribe herbs that really work with where they are in that cycle. So what happens in week 1, week 2, week 3, week 4, and you just try and make it bespoke to that person. There are some people who in Chinese medicine, we talk a lot about, is there this hot blood stasis? Is there this cold blood stasis? Do we need to warm them up? Do we need to cool them down? So when you work with someone who works in natural medicine, what they try and do is look at your individual constitution with it. They're not just like the GPs would say, take this drug, take this drug. We try and look at what's going on with their individual endo and create this plan for them around that.
And in terms of the dietary stuff, because there's so much out there, what do you find, again, that it's really individual? So for some people, like cutting out gluten, say, works a treat, and for other people it doesn't? Or is there sort of some hard and fast rules around it?
someone who's had endo for quite a long time often does have an element of gut distress.
Mm.
So often when you take gluten out of their diet for them, you find that so many things might start to kind of decrease in symptoms. We don't want someone off gluten for their whole life. You know, we want them to be able to eat that broad range of food. But we usually say, let's try and shift from that standard American Western diet, UK diet of bread, pasta, having a piece of gluten in every meal. Let's think more about how many vegetables can we get into our diet here. If we start the morning with, and I often might say, just what you had for dinner, you can still have for breakfast. So try and, make breakfast an opportunity to have vegetables as well. Vegetables are really important for something like endo because it's another way of getting all these antioxidants in the body to help tackle the inflammation.
Mm. Do you, just a random question then, do you see that endo is like genetic? Do you find that it runs in families, or is it like a random condition?
I usually ask my patients, like, tell me about your mum's menstrual history and maybe, your sister. And so many women will say, yeah, my mum had to have a hysterectomy, and they won't necessarily know that she had endo, but she had so many of the similar symptoms. And they might say that, yeah, my sister's really bad as well. So I do tend to see this familial pattern with women that if mum's had it, then they, quite likely to have it as well.
And I guess from if you're trying to conceive with endo, I guess the important thing is getting that diagnosis, isn't it? Because what it sounds like to me is that, and what obviously we see in clinic, is that you need time, don't you? And so it's a very different experience if you're in your late 30s getting the investigations done to if you're in your late 20s, for example.
Exactly. Like if we have got someone who has been investigated and had surgery, late 20s, early 30s, they've just stand so much better a chance of, falling pregnant because they've got the time afterwards to heal and then to start trying. When their surgery is like 39, 40, then we need the time after that for them to heal. So this is why I'm always pushing people to become a nuisance at the GP and just not take no for an answer.
Yeah. And it's the thing, isn't it? It goes right back to that education around, if you're a teenager with painful periods, that is not okay to be, it's not okay because it is a way of coping with it. If you're going through the pain, being put on the pill and you're not in the pain, then that is a solution. But it's just about having that awareness that might need to be investigated. And the sooner that's investigated and properly diagnosed, the sooner you can maybe stay on the pill if that's okay in your early 20s. But if you get to the point where you think in the next 5 or 10 years, I want to have children, you're investigating it before you're ready to have children, if you see what I mean.
Exactly. Yeah. And because you'll be like me, you'll meet so many women who've been on the pill from the age of 15 to maybe the age of 36. You're like, wow, that's 20 years of the endo being there and simmering away, but also there's that cutting off of the menstrual cycle for so long that the body has to relearn what even the menstrual cycle is. So we want patients to be like educated about their own cycle. We want them to go to the GP and ask for more than just the pill if they suspect that there's something else going on there.
Yeah, it's really interesting. I just did a podcast this week. Last week's coming out anyway, sometime soon, with a GP. And she was talking about her experience of, what you're taught when you become a GP. And for each person can decide what rotations they do. They might have a little bit of textbook knowledge, but unless they've got a personal interest in women's health or gynae, they might not necessarily have a breadth of experience to understand it. So they're kind of very much sort of treated if this is the problem, this is the solution, and the solution's always a medication. And, so she was like, we're really kind of constrained by our education when we're becoming practitioners as to what options we have for treatment. So, there are gaps, aren't there, I think?
Yeah. And I would say constrained by the lack of education, because of course they're not getting that education.
Yeah.
And yet it's your GP that is your gateway to further investigation. And I think there's a reluctance for GPs to refer because the way that our NHS works in the UK is, as soon as you start getting into a referral process, the primary care trust, it's more money. So they try and almost hold back the floodgates by just prescribing pills. But no GP can ever tell a woman you do or you don't have endo. And yet this is what I think we're seeing happening.
Yeah. Yeah. And so in terms of what I see a lot as well at the moment is we have lots of people who have got endometriosis who are going through IVF. And often there is an issue around egg quality. So, you know, they might have had surgery for their endometriosis. They've not conceived naturally, so they sort of decide that they're ready to move for IVF. And then when they go through IVF, not with everybody, but quite a lot of people, funnily enough, I'm working with at the moment, there is often this issue of A, the number of eggs that are collected, because has there been some damage to the ovaries? And B, there's always a question mark around the egg quality, and I never seen, and they never seem to be able to get the answer of, is that because of endometriosis or not? Do you have a sense or a opinion about that?
Yeah, I guess we need to think, how long was the surgery before the IVF? Because surgery, as we know, can cause some damage. The body needs to heal from that. The body needs to heal, you know, whatever surgical implementation there was. If there was chronic inflammation there, then we're looking at like 4 to 6 months, I think, to come out of that. So if a surgery and then a woman has IVF a couple of months later, it might even just be a bit too soon. We need to think about, you know, when was the surgery done in the woman's life? Was she 40, 41, which means what we're getting might be slightly compromised as well. But I just think egg quality can always be supported by, you know, good lifestyle. You know, what are they eating? What are they drinking? Are they sleeping? All the stuff that we try and work on with women anyway. Are they drinking enough water? Have they taken out the, you know, the caffeine and the sugar? So egg quality is one of those things that you probably see it as well. The NHS wouldn't really say there's anything we can do with egg quality, but we've seen that nutrients, supplements, acupuncture, herbs can make a huge difference to how that egg, not just the number of eggs collected, but the quality of the eggs collected, how mature they are, and how many get to like the blastocyst stage.
And also, what about the microbiome? Because there is a link, isn't there? And I've seen this a lot recently of endometriosis disruptions with the vaginal microbiome. So we've done a few reports on patients coming through our clinic, and there's a lot that comes up as a result.
Yeah, and that's what we discussed in the conference, right? I did a lot of this in my presentation, because I often see with endo patients, they'll often tell me I've got like itching in my luteal phase. You know, I might have like slightly yellow discharge. Often they will report to me that there is some vaginal discomfort. We're seeing a pattern with women with endo having this bacterial load in their body that shouldn't be there in the vagina. So this is why a lot of us are starting to do these microbiome swabs now, because it shows us just what is in there that shouldn't be in there. And that association with endo, this is partly the research that's starting to come out now, that they think bacteria can be a driver of endometriosis. So as soon as you get someone in your door with endo, you might be thinking, what's their microbiome like? You know, do we need to do some work on that in order to improve the fertility outcome? Because if they've got this vaginal imbalance, having IVF won't solve that. You know, IVF doesn't bypass the issues that we've got with the microbiome. And the good thing about IVF is the fact that they've been able to do so much research on the success of implantation and the woman's like microbiome when she goes into the IVF round. So we've actually got a lot of data and research out of that people who have got a dysbiotic microbiome tend to do worse in IVF.
Yeah, it's quite compelling, isn't it? The evidence that's coming out about that. It's really, it's compelling and exciting, because it's something that you can do something about. It's something that you can test for, and it's something that you can treat, which is always great, because
exactly
so much stuff is like, it's difficult to tell. Egg quality, you know, all these things are difficult, and there's not enough science there. But when there's a report and there's research and there's a clear test and a clear treatment plan, it's good to have some clear avenues in such a complex world.
Exactly. And hopefully we'll get to the point where the NHS are also working with this.
Yeah.
And it's not just those of us on the fringe who are talking about it, because at the moment we still get that response from the NHS consultants. One of my patients took her microbiome results to the consultant, said, I need antibiotics for this. And the woman was like, well, who suggested you order this? She said, oh, my acupuncturist. And the consultant rolled her eyes like, of course she did, But my hope is one day they will also be recommending it.
Yeah. I'm sure the microbiome is going to be the way forward, or one avenue forward, because it is so interesting. I mean, you look at all the stuff with Tim Spector's doing with the Zoe app and all of that. It's like, it's becoming so popular and it's so brilliant because it really works, especially for, all these long-term autoimmune, immune dysregulation. It's such an important part of that jigsaw. So I'm sure it's only going to get bigger. I hope so anyway.
Yeah, and Tommy's have done a lot of research with it, with its miscarriage relation. So I think we're getting there. It just feels a bit glacial for the women that we're working with at the moment.
So just, if there's somebody listening to this who suspects, let's say they suspect they might have endo, or they feel like they would like it investigated further, how would you help them? Like, what would your recommendations be in terms of them accessing their GP? Like, have you got any top tips?
Yes. So first of all, as I said, you need to make a nuisance of yourself, and you need to often make repeated visits and go back. The GP might want to dismiss you, especially if you've maybe had an ultrasound scan and nothing's been seen. But I'm going to read, actually, our mentor, Nava, has this great way of giving patients something to say to the GP to almost encourage them to do the referral. So if you find that your GP is being dismissive, this is one of the things that you can say to them. I've brought you symptoms which I believe are classic endometriosis symptoms. If you're saying that you don't believe that these are worth investigating, and that all the red flags outlined in the primary care guide for endometriosis, which I am exhibiting, aren't valid, then I believe you. Please can you write my symptom list and your assessment into my notes while I'm still here so that I can see they've been noted down. And I imagine there's very few GPs that will sit confidently in that and say, definitely, I'm not going to refer you. So that's one way, take the primary care guide for endometriosis to your GP. And keep pushing for that investigation. But there are a lot of resources online. So we've got the Endometriosis UK charity. Have a look on that. That's a really good resource to have. And then there's something called Nancy's Nook, which there's a website for Nancy's Nook, and there's a Facebook page. And they've got an incredible learning library in there. So the more informed you are when you walk into that GP surgery, the less likely you are to be dismissed. So it's about reading up.
Great. That's really helpful. Thank you. And I'll put all those details on the show notes so people can click on and find out. And the other thing that I was going to ask is, if people want to work with you, or they want to kind of explore, because in my experience of treating endometriosis, it's about getting as much support as you possibly can. So, we often recommend nutrition, acupuncture, fertility massage. It's like we pull out all the stops because it is such a complex disease, and it's important to access the right support. So you also have online support that you can offer, because obviously people listening to this are all over and they can't always access acupuncture. They might not always have, access to nutritionists or those kind of things. So can you tell us a little bit about your program that you have?
Yeah, and I learned I could do this actually in the pandemic, because of course most of us were shut down for about 3 months, weren't we? And we couldn't actually practice part of the medicine that we practice. So I realized that I could still get all of these really good results, first of all by practicing herbal medicine, but because the world of Zoom exploded, I realized that I don't just have to support the women in Newcastle. I can support women around the country that might live in rural, remote areas that don't have access to fertility specialist acupuncturists like ourselves. So I created this online support for people, like an online program, which is also to support acupuncturists who don't do what I do, who aren't necessarily specialised in endo, who aren't doing herbal medicine. But for anyone who might be seeing an acupuncturist or who doesn't like needles, because how many women, are also needle phobes, then what I can do with people is this online Zoom support where I can prescribe the herbal medicine, make all the lifestyle recommendations. We can do the microbiome testing, and I can offer that fertility expertise just like I do in the clinic space as well.
Amazing. So I will put all those details on the notes as well, because I just know that people really struggle as to that people get lost, don't they, in the system as to like, where can I go to get further help? They've sort of tried the GP route, they've tried the sort of Western medicine route, and it always gets them so far.
Mm-hmm.
And it's about looking at other ways, I think, to support you, because it is a whole body issue, isn't it?
It is.
And so you've sort of got to have that, take a step back and look at the whole body in place of the life as well that person's leading, to really, really impact change.
Yeah. And also we get so distracted by the fact that patients got endo, that sometimes can become like, oh, endo is the problem.
Yeah.
But sometimes it takes us stepping back and going, actually, tell me a bit more about your partner.
Yeah.
Oh, he had mumps when he was a kid, you know.
Yeah. Yeah.
And we have to remember to treat the couple, not just the woman, right?
Amazing, Louise. Thank you so much for your time. I will put all the details on the end of the show. It's lovely to have you. Thank you.
Thanks for having me, Hannah. This has been great.
So I'm just going to say this because I always forget and I keep getting told off. If you have enjoyed this, it would be really good if you could give us a review. So apparently somewhere on Apple Podcasts, you can do it. I've tried it myself. It's a nightmare. If you find it and you can give us a review, we would be so grateful. And on podcast, on Spotify, you can just do a rating. So that would be great as well. So I hope you found this episode helpful. All the information is at the end of the show, and all Louise's contact details will be there as well. So we will see you next time. If you've enjoyed listening to this and want to find out more, then come and join my free community in Facebook. We have loads of resources. You can catch up on all our previous webinars and be the first to know about forthcoming events. To sign up, just follow the link in the show notes. And if you'd like to work one-to-one with myself or one of the team, then please see our website, hannahpern.com, where you can book in directly or organise a discovery call to find out how we can support your fertility and your reproductive health.